This is Chapter 27, Chemical Agents in Periodontal Care. Chemical agents, there's systemic delivery administering chemical agents such as an antibiotic in the form of tablet or capsule. The chemical agent is released as the tablet dissolves and enters the bloodstream and circulates throughout the body. Topical chemical agents in a periodontal pocket can contact biofilm. So examples, a mouth rinse or a toothpaste that contains a chemical agent that can kill bacteria. Biofilm resistant chemical agents. So remember that plaque or that bacteria involved in plaque biofilm, gram-negative. The bacteria have a slime layer around them that acts as a barrier to preventing some chemical agents. So this is where a topical agent would not be as effective because of the slime layer. Mechanical disruption is still the most important to allow chemical agents to reach the bacteria. So in other words, brushing and flossing to mechanically disrupt biofilm would allow the chemical agent then to be able to go through the slime layer and attack the bacteria. Delivery mechanisms for chemical agents, you've got mouth rinses, dentifrices or toothpaste, subgingival irrigation, controlled release delivery devices, and systemic tablets or capsules. So microbial reservoirs for periodontal pathogens. Bacteria can live in protected sites and function and furcation areas. They can live on residual calculus deposits that weren't removed during scaling and root planing or regular perio maintenance. They can live inside connective tissue. They can live in dental tubules, protected by irregularities in tooth surfaces, and they're protected by bulky restoration margins. So basically anywhere bacteria can hide, they're going to be hidden. So what makes an effective chemical agent? So to be effective, it must meet 3 criteria. It must be able to reach the site of the disease activity, so the base of the pockets where most of your disease activity is going to be occurring. And remember, the deeper pockets, harder it is going to be to reach. Ability to be delivered at a bacteriostatic or bactericidal concentration, so it must be able to have an effect or kill the bacteria, and it must be able to remain in place long enough to do that. We talked in the last chapter about water irrigators and how they don't stay in the area long enough to be very effective. So when you irrigate with chlorhexidine, you might get a little bit of effect, but it rinses right out of the area. It doesn't stay there. Chemical agents effective against periodontitis. There's no chemical agent that can halt or stop periodontitis. There are a number of different agents that can be used as part of your plan or part of your treatment, but none by themselves that will halt periodontitis. So some of your chemical agents might be antibiotics, antiseptics, fluorides, metal salts, oxygenating agents, phenolic compounds, quaternary ammonium, and tertiary amine surfactant. So what are all those things? Let's start with systemic antibiotics to control biofilm. So systemic antibiotics, these would be antibiotics that you take orally that travel throughout your body. They're used to fight infections either because they kill bacteria or because they can inhibit the growth of bacteria. Systemic antibiotics can be taken orally or can be injected. Clinicians should avoid routine use of systemic antibiotic drugs to control gingivitis or chronic periodontitis. Why should they avoid the use? Because the antibiotics are also killing other bacteria within the body, and so they can cause a lot of gastrointestinal upset when they continuously kill the bacteria that are good bacteria in other parts of the body. They also become less effective because of antibiotic resistance, so they cause your body to build up more resistant bacteria. Examples would be penicillin, amoxicillin, tetracyclines, and erythromycin, metronidazole, and clindamycin. All of them are commonly used in dentistry for various reasons. We talked about bacterial resistant. When a patient learns that gingivitis or chronic periodontitis is a bacterial infection, it is common for him or her to ask about the use of antibiotics. Tetracyclines. Tetracyclines are antibiotics, but they also have a different property that makes them effective against periodontitis. They can inhibit the action of collagenase. Collagenase is an enzyme that destroys or breaks down collagen in the periodontium. And so they can inhibit the collagenase enzyme. Controlled release. Controlled release delivery device is an antibacterial chemical embedded in a carrier material placed directly into periodontal pockets. So we use controlled release delivery a lot in dentistry. Its effectiveness is questionable as to how effective it is in dentistry, but it is used quite often. The carrier material dissolves slowly, producing a steady release of antimicrobial agent over a period of several days within the periodontal pocket. So chlorhexidine and antibiotic drugs are currently used. Why do we do them? To subject subgingival bacteria to therapeutic levels of a drug for a sustained period of time. So we talked about the antibacterial agent being able to stay in a place for a long time. So during subgingival irrigation, it doesn't stay in the pocket for very long, and therefore it's not very therapeutically effective. So they came out with ability to have a controlled bacterial controlled antibiotic that can stay in the pocket for a long period of time. The benefits is when used along with periodontal instrumentation, they can result in both an improvement in probing depth reduction and clinical attachment gain. So there's a lot of controversy out there about how to properly use these different types of controlled release delivery medicines. And you can ask a lot of different people how to use them, and they will all give you different ways to use them. Some of them include minocycline gel, which is Arestin, and then there's a doxycycline gel and a chlorhexidine gluconate chip. So the minocycline, all of these, how to apply them, I wouldn't test you on, but minocycline is placed with you identify a pocket, and then you take the tip of the, it's a little plastic-like tip, and it's got the powder embedded in the tip, and it goes in a syringe, and so you slide that tip into the pocket, and you push on the end of the syringe, and it pushes the powder into the pocket. When the powder mixes with crevicular fluid inside the pocket, it kind of gels like, and it sticks to the side of the tooth. And then slowly over 5 to 7 days, it will dissolve. So it has like a continuous bacterial effect or bactericidal effect for about 5 to 7 days, which allows enough time for the gum tissue to heal and re-adhere to the inside of the pocket. And there's a doxycycline gel, which is delivered in a gel. So it was basically the same thing. It was a gel that's inside like the tip of a plastic tip, and you put the gel inside the pocket, and the gel would stick to the side of the tooth and slowly dissolve over a period of time. The downside to that particular product was that the gel would stick to the end of the tip of the applicator, and so when you pulled the applicator back out, it would stick and pull out as well. And so it was kind of hard to keep it down in the pocket without having it come back out. So it wasn't as effective of a product. And then you have a chlorhexidine gluconate chip, which is a chip that, a little disc-like chip that would insert into the pocket. So you would take cotton pliers and you would slide it into the pocket. But it had a similar kind of issue with it where it would stick sometimes to the cotton tip and then you would, or to the cotton pliers, and then you would pull it back out and it would keep coming back out. Mouth rinses. So we use a lot of mouth rinses. Therapeutic mouth rinses. So there are lots of therapeutic ones. There are a lot of mouth rinses on the market, all of which are therapeutic. A lot of them are just breath fresheners. Listerine happens to be one of them. Characteristics of an ideal mouth rinse is its efficacy inhibits or kills periodontal pathogens. Stability, it's stable at room temperature and has a reasonable shelf life. Substantivity, it can be retained in the oral cavity and released slowly over several hours with continued effect. And safety, it does not produce any harmful effects. So the active ingredient in most mouth rinses is a component that produces a benefit for the patient, such as a reduction in gingivitis. And then you've got inactive ingredients, which give it the good color and taste and keep it as a preservative in a liquid state. Effective ingredients in mouth rinses can include chlorhexidine, essential oils, cetylpyridinium, and delmophenol. So most commonly chlorhexidine. Chlorhexidine is a prescription, and we like to keep chlorhexidine for bigger issues. Chlorhexidine causes a lot of staining of the tooth surface, and so if you put a patient on chlorhexidine every day, they're going to constantly have brown staining on their teeth. Essential oils are in Listerine products, so they are good for the gums and they're excellent for killing bacteria. So highly recommended essential oils. Cetylpyridinium is in Cepacol mouth rinse, so it's just another type of killer. Essential oils are probably more popular, but cetylpyridinium has grown in its popularity. It's the active ingredient in some newer mouth rinses. So chlorhexidine is available only by prescription in the United States. It's proven to reduce gingivitis in numerous studies. It's effective against gram-positive and gram-negative bacteria. It binds with hard and soft oral tissues and is slowly released. So it is an excellent mouth rinse, but it's just not one that we want to use every day. The primary mechanism of action is the disruption of the integrity of the cell walls of bacteria. It's used twice a day for 30 seconds as part of a patient's routine home care if you're using it as a home care aid. Groups of patients that would benefit from it, again, I would, post-surgical is usually when I see it used. Patients with oral piercings a lot of times will use it. If you have xerostomia and you use chlorhexidine, you're going to get really bad staining. So that's just something that for some patients that's okay. Most patients don't really particularly like that. Essential oils have been used as active ingredients for many years. The four essential oils are thymol, menthol, eucalyptol, and menthol salicylate. It's available over the counter, such as Listerine. They have the ADA acceptance seal. They can help control biofilm, and they're less expensive than chlorhexidine, although chlorhexidine has come down in price a lot. They now make Listerine that does not have alcohol in it, and so that has made Listerine a much, much more popular product out there. ADA seal of approval. So you're going to find a lot of products and patients using products that are all natural, contain no preservatives, contain no harmful ingredients, that do not contain the ADA seal of approval or seal of acceptance. So you're going to do a lot of research probably in your time as a clinician as to the use of these products. We recommend science or evidence-based products. A lot of your all-naturals don't have evidence-based, but that's something you can take with you and research later on. Coronary ammonium compounds, This chemical is released so rapidly that it's very little substantivity, limiting its effectiveness. So it's less effective than chlorhexidine or essential oils. And then mouth rinses with delmopanol. They cause tooth and tongue staining. Effectively, it reduces the severity of gingivitis and biofilm when used with mechanical biofilm removal. So all of these products are useful when you also combine them with good mechanical removal of biofilm. In them by themselves, they're not going to be quite that effective. So the problem with the ingredients is possible side effects. Chlorhexidine, again, discoloration of the teeth, discoloration of the tongue. It's a brown color too. It's not just like a light surface staining. It's a nice, good brown color. It also alters your taste. So if you use this product, some of your foods are not going to have the same taste that you would like them to. Increase in calculus formation. So it can increase your calculus formation, mainly because the staining causes a rough surface area, allowing for calculus formation. Essential oils can dry out your mucous membranes because they do usually contain alcohol, and so they can dry out mucous membranes. Inactive ingredients have high levels of alcohol and should be avoided, particularly in patients that have an alcohol addiction or have had an alcohol addiction. They also have high levels of sodium. It says so should be avoided with certain hypertension patients. I'm not really familiar with keeping hypertensive patients off of mouth rinses, but ADA classification of dentifrices, you've got anti-tartar activity, caries prevention, cosmetic effects, gingivitis reduction, plaque formation reduction, and reduction of tooth sensitivity. These are in toothpaste. So when a patient goes to the market to buy toothpaste, there are all kinds of things they can look for. Anti-tartar activity is a good one. Tartar Control. Tartar Control and whitening toothpaste can cause some tissue sloughing, where like the inside of the soft buccal mucosa can peel a little bit. And so if it peels too much, it can cause some irritation or sensitivity. If you see that in a patient, I would usually just have them switch whatever product they're using, because it's usually the anti-tartar component or the whitening component. Caries prevention, they all usually contain some level of fluoride. Fluoride gets a lot of public attention. There are a lot of people that avoid fluoride in toothpaste and mouth rinses. You're going to see a lot of patients that do that, or you yourself, or you may know people that do. So do your research on what products are out there and available for patients to use. Cosmetic effects usually are whitening. So whitening agents are in a lot of different toothpastes. Gingivitis reduction, so you're going to have toothpaste that have different things to help for gingivitis. Stannous fluoride is now in toothpaste for periodontal control of periodontal diseases. Stannous fluoride can also stain teeth, and it also has kind of a bitter taste, so a lot of patients might not like the taste of it. Plaque formation reduction, there's a lot of products like Plaques that you may have seen out there. Reduction of tooth sensitivity, so toothpaste that contain some levels of fluoride to help with tooth sensitivity. Toothpaste that contain active ingredients for sensitivity. So those you will probably recommend a lot, like Sensodyne, potassium nitrate, potassium citrate, sodium citrate. So examples of the active ingredients, pyrophosphates. So pyrophosphates are in toothpaste that prevent calculus formation. When you use a toothpaste that prevents calculus formation, it prevents the formation of new calculus. It does not have any effect on calculus that's already formed on the teeth. Stannous fluoride reduces gingival inflammation, but stannous fluoride can cause some staining and bitter taste. Triclosan. Triclosan kind of goes back and forth with its safety issues. Triclosan is commonly used in antibacterial hand soaps. It reduces supragingival calculus and gingival inflammation, but there's been some controversy in the past about triclosan in toothpaste. Zinc citrate reduces supragingival calculus. So educating your patient on the use of unconventional dental products and remedies. Charcoal dental products. I am not very familiar with a lot of these non-traditional ways, but you will hear people that use different things. It's used as a powder or a paste. Is porous and thought to trap oral bacteria. It's abrasive and may cause abrasion and gingival irritation. Claims of effectiveness are anecdotal or not scientifically proven, and there are no proven benefits and therefore not therapeutic for patient use. Oil pulling. Oil pulling is another one. Current oils used are olive oil, palm oil, and coconut oil. There's a belief oil traps bacteria while being held or swished around the mouth for 10 to 20 minutes. So if you can imagine holding oil in your mouth for 10 to 20 minutes to kill bacteria. Again, not scientifically proven. And since there's no existing scientific basis for claims, the ADA and the CDA both state there is no therapeutic benefit to the patient. So when you get out in practice, you can talk to patients and educate patients on the effectiveness of some of these different types of procedures and products.